Hi, this is Walt Fritz from Foundations in Manual Therapy Seminars. Over the past decade and a half, I've moved from a model of myofascial release, which was minimally evidence-based, on purpose, it was said, because the best evidence was our patients' happiness and satisfaction, which of course that matters, but I learned we can do better. So, the last decade and a half, I've been really working to try and find a really good evidence-based approach model for teaching this work. I know, just call it manual therapy, because I don't believe we can target the fascia selectively. But, I'm really struggle sometimes when a new paper comes across my computer and what looks like a promising study in terms of the outcomes is so difficult to understand. It's like, how are we supposed to translate this, published research, from working directly with the patient? Because in a way, that's what we're expected to do. We're supposed to take the best available evidence, interpret it, and then apply it to our patients. I've got a paper here that just came out a couple weeks ago on the effects of manual diaphragmatic activation on diaphragm functions in patients with gastroesophageal reflux disease, or GERD. Important stuff for your quality of life, for vocal disorders, that sort of thing. But when you try and read this paper, can you, as a clinician, make sense of this paper in order to apply it to your patients? I have a pretty, extensive background in this model that this paper was presented from, which is pretty much a myofascial release model. I recognize some of the terms, but there's so much coding and encrypting of techniques that, to me as a clinician, it gets very difficult to decipher. And, I look at myself as maybe in a better position than a lot of speech pathologists and other people using the work that I teach in the manual therapy for voice and swallowing disorders seminars. And I wonder, how are they supposed to translate a paper like this in the way we're supposed to in order to apply it to the patient? I'm going to give you an example. This paper was one where they took a look at some indicators. Number one was the patient's diaphragmatic excursion, movement of the diaphragm, diaphragmatic thickness fraction, and I'm not 100% sure what that is, but it was, I believe it was something that they measured with ultrasound, as well as a Pittsburgh Sleep Quality Index. So some relatively objective measurement tools they were using before and after. But it was the intervention itself, which to me, part of it was quite simple. Part of it was so codified and confusing that, reading it and rereading it, I still question, would I be doing exactly what the study was intended? So let me briefly run through this for you in case you're curious about this particular study. They had the patient positioned in a hook line position, hips and knees at 90 degrees. And the first step was ask the patient to simply, I guess they taught diaphragmatic breathing to the patient, to engage in diaphragmatic breathing for 5 minutes. Step number 2 was something called a diaphragmatic transverse plane technique. Now, I recognize this from early myofascial release and craniosacral therapy days, where a clinician took a hand and got it underneath that T12 L1 junction on the bottom and then came up on the top. And depending on whose model you were taught from and you practiced from, it's basically in the craniosacral model, doing nothing or nearly nothing, or the myofascial release model, doing some shearing, compression releases to this area that was said to affect the diaphragm. And often, even early on, I saw that patients often had a very profound relaxation effect from it. Was it from what we did with the diaphragm, which is pretty much buried deep in the body, or was it affective touch provided in a way that the patient felt a calming reaction from a safe, hopefully interventionalist like mine? Hard to say. Autonomic changes are as much a part of this as anything we think we're doing deeper in the body. So 5 minutes of that. And then what they did was a few of the more difficult to follow techniques. One of them is called a diaphragm stretching technique. And, I made a note here for myself. I know this style of work, and I still cannot fully decipher the intentions of and actions of this paper. Basically, they had the clinician stand up here at the head and put the hands on the lower aspect of the ribs. And then the patient would take some successive deep breathings, and I would exaggerate a downward movement on the diaphragm. Next came, in the same position, I'm going to, instead of moving with them, I'm going to resist the inspiration. So basically, the patient's trying to expand the rib cage, and I'm trying to resist that. And then the most confusing part of this is then it says something to the effect of, I then follow it by stretching the diaphragm in a simultaneous lateral and cranial direction after the patient's expiration. And again, there's no photographs, there's no images, there's just a very awkwardly worded phrasing, which I'm not sure whether we're supposed to go this way, caudal or towards the head and lateral, or somehow do the same thing from here. Again, it's indecipherable to me. They followed it then with 5 minutes of diaphragmatic breathing, and then the patient was encouraged to learn self-release to be performed at home. That was literally the sentence. The patient was then encouraged to learn self-release to be performed at home. Now, all of these studies leave a lot of room for our interpretation. I get that because I certainly interpret a lot of the studies based on my own biases and my patient's biases, that sort of thing. But for a new clinician who's tasked with trying to read a study and figure out, okay, I'm supposed to follow this, but how can I when it's non-followable? I think it really makes it not just challenging, but impossible for us to really take this home to each and every patient. What am I getting at with this video? Number one, there's a lot of good studies out there, but number two, they're really difficult to translate into practice. And I think the onus should be on these researchers, should be on the people who are writing these papers and editors of journals to take a look at these papers and say, can we really expect that someone can follow through on these procedures based on what was written in the study? And I read a lot of these studies. I read a lot of these studies that apply to voice, swallowing, breathing, etc. And I can't follow them. And I kind of know this stuff. I don't know how other people are expected to do. So I think what it takes is a voice. What it takes is more than one voice. It's a lot of voices demanding from journal publishers, from authors themselves, to really get on the stick and write a paper that we can actually practice from. If you have any questions or comments, I'd love to hear them. Whether you want to email me or make a comment here. Thanks for watching.